Okay, so I'm going to turn it over to Heather, but I am just going to give a brief introduction. So you're aware who Heather is. Heather Hafer is a clinical supervisor for Karen's entire women's continuum, including teen, young adult, and adult women programs. She has a master's of science degree in psychology and an undergraduate degree in applied psychology from Penn State. And she's currently working on her PhD in addiction psychology. She's also a certified advanced alcohol and drug counselor and a certified clinical supervisor. So I'm going to turn it over to Heather. It's all yours, Heather.
Thanks, Mallory. Hey, everybody. We're going to talk about the treatment alphabet. Sort of what Mallory introduced us with is oftentimes treatment providers, we have our own language, our own lingo, and it's common to us. And a lot of times our patients and our families don't understand all of that. So what we're going to go through today is just a couple objectives, wanting to learn about the verbiage used in treatment settings, and that's any treatment setting, and we'll go over that. Talking about how recommendations are made for levels of care, continuing care, other placements, and then understanding what that is and how that's made. So through the presentation, you'll see a lot of acronyms, a lot of letters. I'm going to go through that and talk about it. I really welcome any questions as the slides are happening, if you have them in the moment. And if not, we'll chat at the end. What I always like to start with, though, is really taking a moment to think about substance use and care, both being on a continuum. So at the top of the slide, you'll see a substance use continuum. The bottom is the care continuum. So starting up at the top, whenever we think about treatment and substance use, we often think about that very last corner, the substance use disorder. And there's two other pieces to the story. So there's this idea of positive physical, social, and mental health. This is, our status of well-being, free from substance misuse or use. This is when people are able to be fully in their abilities and capabilities. They're able to manage in life, employment, education. But this is typically where we see health and wellness. And when we start to recognize maybe maladaptive coping, unhealthy use of substances, maybe seeking out additional chemicals if we're already prescribed something, that continuum starts to move into that misuse category. So that center square there. And this doesn't necessarily mean somebody has a substance use disorder or an addiction, as many people call it, but this is really an area of awareness and mindfulness that our substance use, our chemical use is being misused. We're using it in ways that can start to harm us. They start to show up with consequences in our lives. Maybe our loved ones start to notice changes in behaviors and attitudes. If that continues and we continue to move in that sort of way of misuse, we can find ourselves, or our loved ones can find themselves in that last block, that substance use disorder piece. And this is oftentimes when we talk about treatment, where many people think about their loved ones or their family members. So substance use disorder is when misuse has moved into dysfunction. So we start to experience significant consequences. We start to experience issues with health, wellness, mental health, responsibilities in a social manner can be impacted. This can be employment. Maybe this is showing up for things for our family, for our community. But we start to recognize that the substance use has taken a primary sort of standing within that person's life. If we have that continuum up top, that positive physical, social, and mental health, the movement to misuse, the movement to substance use disorder, there also needs to be a care continuum, which you'll find on the bottom of this slide. We often think substance use, treatment, address it, help the person, let's get them sober, or let's give them some awareness. And treatment, very similar to substance use disorder, is on the further end of the continuum. If we think about how we can jump into people's lives, there's really a couple steps before we get to treatment. You'll see the first box is enhancing health, and it really goes hand in hand with that first positive physical, social, mental health. So, enhancing health is when we are well, our loved ones are well, as it says, promoting optimum well being. So, this is utilizing health services, utilizing community resources, practicing self care, finding those things that fill us up and keep us centered and grounded. If we enhance health, we're truly in tune with what our bodies and our brains need. And we as humans, our loved ones as humans, sometimes move from that. So, as a care continuum, primary prevention is typically what people will start to think about when we start talking about mental health and substance use support. Going through school, I remember going through DARE classes. That's a great example of a primary prevention. It's education, it's information, it's putting it out there in the community for people to learn about. It's not necessarily identifying specific people, identifying certain groups, but it's program and policy to provide education and awareness. Early intervention is when we start to identify the individuals who might need some support. So we might see early stage movement from that positive health that we talked about at the beginning of the substance use continuum. This could be brief interventions. Maybe this is where a loved one might start seeing a therapist, or maybe a loved one talks to somebody in their family who has also been on a health journey or a wellness journey. This could be a young person in school who maybe sees their counselor there, or if there is a student assistance staff member. Early intervention is the opportunity for us to jump in some capacity to provide support and direct information and education to that person who might be starting to misuse substances, maybe abuse their prescription, seek out other things to make them feel well or better. As that misuse continues, we talk about that substance use disorder. This is where treatment, or at least what we historically think about as treatment, happens. So in the care continuum, this is true intervention. This is therapy, could be medication, it could be outpatient, residential, maybe it's a medically managed experience. But what this treatment block does is it helps to move people, or aims to move people to a place of sobriety, abstinence, health, wellness, which, as you'll see in this block, includes physical, spiritual, mental health. It also includes social well being. In that block, you'll see that it references different levels of care. They're there for now. I'm going to highlight that on a different slide in a little bit. But what I like about those bullet points is it really brings to light that treatment itself is its own continuum. There's no one stop shop. There's not one specific thing that you have to do to help and support somebody who maybe is struggling with substance misuse or use. There are many, many options out there. And within those levels of care, there's ways to move throughout them to best support that person. In our care continuum, as people engage in treatment, whichever level of care is most appropriate for them, the goal is to get to recovery support. So, with sobriety, with abstinence, recovery support is about removing barriers. This is how do we provide foundation? How do we provide wellness to the individual who just went through some level of treatment, address their substance use disorder, maybe their mental health, underlying maybe communication or family boundaries. But recovery support can look like ongoing therapy, maybe support groups. Traditionally, we talk about AA or NA. Maybe it's sponsorship. This could also be self care, new hobbies that they've learned. Again, ways to fill them up which is very similar to that enhancing health piece. So, what we know is if we can get into recovery support, then the enhancing health almost moves over to the other end of the continuum. And those two play really, really well together. A continuum is just that. So, our hope is that if somebody's in the top and they go from positive to misuse to substance use disorder, our hope is they get to positive and stay there. What we know is there might be some movement back and forth until somebody hopefully gets to that place of wellness. Similar in the care continuum, people can move back and forth between treatment, recovery support, and enhancing health with the hope that they eventually end in that health category. Any questions on any of the continuum pieces before we start looking at some acronyms, how this plays into treatment, how this plays into levels of care? Okay. So the first slide said substance use quite a bit. Substance use disorder. Where this comes from is our DSM 5, which is the Diagnostic Statistical Manual, the fourth edition. And this is sort of like the holy grail, the end all be all of how diagnoses are assigned to people. The DSM has a chapter on substance use, but it goes over all mental health diagnoses. In substance use treatment, we really do look at that one chapter for the different substance use pieces. There's also a category in there for gambling as an addictive process. We say substance use disorder. In the past, people said addiction. We still say addiction, and the correct terminology is substance use disorder. So you'll see SUD quite a bit, and that's what it's referencing. There's also a lot of stigma for some people and some communities around the word addiction, addict, alcoholic. And it's much less of a stigma for people to identify with having a substance use disorder. So we've seen people in treatment actually self-identify quicker and easier with that terminology compared to identifying as having an addiction. In treatment, when I'm working with somebody, when my team is working with somebody, it's not uncommon for us to say, I'm not here to tell you what you are or are not. I'm not here to tell you if you are or are not an alcoholic, if you have an addiction. And what I can tell you is you've been diagnosed with a substance use disorder. That allows them to sort of walk through with us and getting comfortable with knowing that their substance use has been negatively impacting them rather than the stigma of addiction. We talk about assigning the substance use disorder to them. And what you'll see on this slide is that there are criteria associated with those diagnoses. I'm going to walk through these. This is the general criteria for assigning a substance use disorder. So all chemicals outside of hallucinogenics, there's 11 criteria that the DSM provides for us to assess if somebody has a substance use disorder. There's several sections in here. So the first section or group of criteria is the impaired control. So criteria 1 through 4, when we're assessing with a patient, is really looking at how has their control been impaired because of their substance use. So are they taking more or are they using more than they intended or using longer than they intended? This could be expecting to have 1 or 2 drinks and 6 or 7 are gone, or they wanted to stop at 8 so they could get to bed and it's 2 a.m. and they've yet to get there. This persistent desire or the unsuccessful efforts to cut down or manage. So saying that I'll only use 2, truly wanting to only use 2, drink 2, have X amount, and struggling to do that, chasing the high, chasing the feel good, and doing that dance with ourselves over and over again can be that unsuccessful effort. If there's significant time spent to either obtain, use, or recover. So this one for criteria 3 has those 3 underlying points. So for some people, it's really easy to obtain their substance. We often talk about alcohol, especially for our young adults who turn 21. It's legal for them. It's quite easy, especially in the state of Pennsylvania, to pop in grocery stores, in almost any sort of shopping area. There's a liquor store, but it's often easy to obtain the substance. The use, depending on the chemical, can also be easy. A lot of people, however, talk about the recovery from their effects. So, do they have a hangover? Do they feel sick? Are they physically unwell? So, for criteria 3, it's really looking at, do we spend a lot of time to get the chemical, whether it's alcohol or something else? Do we spend a lot of time using or figuring out how to use the chemical? And then what's the time like when we have to recover? The fourth one is craving. So if our loved ones experience a craving or a desire to use the chemical or substance, a lot of times craving for the person in treatment or the person being assessed is a really tough piece for them to get to. Craving is not the grabbing onto something or balling up your fist and just absolutely needing that chemical in the moment. Craving can also be wanting to help recover from the effects. So we're looking at criteria 3 again. It could be chasing that high. It could be wanting to fall asleep easier and knowing that we can't fall asleep unless we use. Craving isn't often just the in the moment need it. So we do a lot of education around craving and what that truly is in substance use treatment. The next section of criteria is social impairment. How around us have we been socially impacted? So criterion 6 is failure to fulfill major role obligations. This is employment, education, or at home. So are we negatively impacted at school? Are our grades going down? Maybe we have to drop out. Maybe we have to withdraw. Am I being reprimanded at work? Have I been passed up for maybe a promotion? Am I being written up when historically I've been a great employee? Or at home, do we notice some behaviors and attitudes of change? Are we getting into more fights? Are we arguing with our loved one? Do we find them isolating more? So we're looking at how the substance use has impacted those 3 areas. Criterion 6 is when we continue to use despite having those issues. So we're continuing to use despite having either social or interpersonal impact. Our families have expressed issue with our chemical use. Again, we've been written up at work or passed over for a promotion. We continue to use, even though that was part of that. Or criteria 6 is really when we start to see the consequences because of the use. And it's not just people around us saying, like, hey, do you think you might be using too much? Or do you think that might not be healthy? We're starting to see actual consequences. 7, social, occupational, and recreational activities are either given up or reduced. So when we find people start giving up their hobbies or maybe not doing them as passionately or as often, do we find our loved one who typically was so social and engaged with the family system doesn't engage in those family dynamics anymore? Maybe they're not going to family dinner, or maybe they're not calling their aunt and their uncle who they historically have. But for number 7, we're really looking at how socially, occupationally, and recreationally activities are changing. And often when we see them changing, we're seeing an increase in the chemical use. The other 2 sections within our SUD criteria are risky use. So in number 7, we're talking about how those activities are lessening and we're seeing an increase in substance use. Number 8 for criteria tells us or asks us to assess if there's situations where use has also been physically hazardous. So we know chemicals in general are not good for the brain and the body. And are our loved ones driving under the influence of alcohol or other chemicals? Are they putting themselves in communities, locations, areas which otherwise they would not go to and can be a risk of their safety and health? We're looking for situations where mentally, emotionally, and physically our loved one could be negatively impacted. Number 9 is, again, using that substance, knowing that we can put ourselves in those physical or psychological impacts. Um, so if number 8 is being met, what we're looking at with number 9 is the individual recognizes that I'm doing dangerous things, I'm doing high risk behaviors, or I'm in high risk situations, and there's a continued action in those high risk examples because of the chemical use and the continued chemical use. The fourth section is pharmacological. And these are the two that oftentimes loved ones, family system supports identify most easy for our loved ones. Tennis tolerance. We know tolerance as the general need for an increased amount. So they used to be able to only use X, and now they need 5 times, 6 times, 7 times as much to get the same desired effect. Maybe growing up, maybe shortly after 21, whichever it was, they had a glass of wine at night, and there was a progression to a half bottle or a bottle of wine a night. That's tolerance where we need more and more for that desired effect. There's an opposite to that, though, and a lot of people don't often recognize or know about. Tolerance can actually have a diminished effect with continued use of the same amount. What that means is typically the physical body has been so impacted in a medical way that we are going to be drinking or using and achieving that desired effect, unfortunately, quite quickly. We often see this with later stage people who use alcohol because of liver impact, that they used to drink quite a bit, again, trying to get that desired effect, where now they're not drinking as much and becoming intoxicated because their liver can't process the amount of alcohol anymore. So we start to see almost a backwards effect with tolerance. 11 is withdrawal. And this is a combination of mental, emotional, or physical symptoms. It's not always just physically how the body reacts to not having the chemical in it anymore. We often talk about, the shakes, the sweats, the GI upset with opiate withdrawal. There's also significant mental impact with things like stimulants, methamphetamine, cocaine, even Adderall, where the brain races. It's very, very difficult to sort of slow down. And then a need for sleep for the body to catch up. So there's a whole range of different withdrawal that can be experienced depending on the chemical, how the chemical was used, and how long it's been used. What we will also talk about, though, with withdrawal is when our loved ones are identifying with experiencing that, they often talk about using a chemical to not have withdrawal. So, our young people in treatment will talk about being dope sick, needing to utilize or use an opiate in some capacity before withdrawal happens because they know it's going to happen due to the chemical, due to how long they've been using, but wanting to avoid that. So withdrawal we can assess in those two ways. With all of those 11 criteria, what the DSM tells us is depending on how many criteria each one meets, that person will be assigned a severity level for their substance use disorder. So if somebody meets 2 or 3 of those 11 criteria, they'll have a substance use disorder mild. 4 or 5 criteria is a moderate, and a 6 or more, so 6 to 11 criteria being met, is severe. It is a continuum. So somebody may experience an opioid use disorder severe and an alcohol use disorder mild. Maybe at one point in their life they were mild. As their consequences increase, they get to a moderate or severe. But just like care continuum, substance use continuum, our substance use disorders have a severity continuum. Any questions on any of that? Okay. So, as we're assessing for substance use disorders and in that care continuum, when we talk about treatment, we talk about levels of care. So, when your loved one comes to treatment, whichever level that is, we often do talk about level of care and we reference it as an LOC. LOC is simply level of care, and that continuum starts with that early and that prevention piece. And in the next slide or two, we're going to go through that continuum so you can see how levels of care build on themselves. In treatment, when we're assessing for levels of care, we talk about ASAM criteria, which is the American Society of Addiction Medicine. This is what our healthcare providers in the substance use field utilize to ensure that we're recommending the best and most appropriate treatment level for that person who's being assessed. And then LOS often goes hand in hand with LOC, but LOS is a length of stay. So after your loved one's assessed, we figure out what level of care they're going to go to. We also talk about length of stay. Is it a month of treatment? Is it 6 months of sober living? But that length of stay is often also part of the conversation as we talk about which level of care that person's going to go to. So when we talk about levels of care and we've assessed through ASAM, there's a few that can happen. So I started at our sort of higher level of care and dropped down. So a lot of times when we talk about treatment for substance use, we talk about quote unquote rehab. What we're really talking about is a residential level of care where somebody lives at their treatment center and receives their care in that same place. Karen, in Pennsylvania, up in Warnersville, we are a residential level of care. Our loved ones, our patients are living in the same place that they're receiving their treatment. If we step down from residential level of care, there's PHP or partial hospitalization program. You'll see in parentheses, I have HIOP, which is a high intensity outpatient program, which is new terminology for ASAM4, and I'll talk about that in a little bit, but how they are going to start talking about PHP. PHP is a high level outpatient experience. So, a loved one engaging in that is typically going to treatment 4 or 5 days for 4 or 5 hours a day. The difference between residential and PHP, though, is the loved ones in PHP or high op are actually living at home or in some form of recovery residence or sober living. A drop down from PHP is then IOP, intensive outpatient. This is typically 3 days a week for about 3 hours a day. Again, they can be living at home, engaging in IOP or supportive recovery residence. But typically, IOP is for either people with a less severe substance use disorder or people who have completed higher levels of care. This is a really great option sometimes for people when they're resistant to a higher level, like a PHP or a residential, or they're still exploring what recovery looks like for them. And then we drop down to outpatient after IOP. So OP, outpatient can really be different for whichever program your loved one's in. This could be a group a week for 2 to 3 hours. This could be a recovery maintenance group. This could be maybe a trauma focused group, but typically this is a 1 or 2 time experience during the week, some combination of group therapy and individual therapy. This is just a really pretty slide that I think makes it really easy for us to look at what we just talked about on the slide before. So ASAM, the American Society of Addiction Medicine, provides this really great visual of levels of care. What you'll see is there are 4 levels. There's the inpatient up at level 4 in the red. This is typically going to be a really high intensive structured level of care. People who are medically compromised, who need to have 24/7 medical attention in addition to receiving support for substance use. Level 3, residential. For example, Karen, as I just talked about being residential in Warnersville, is on this level in the orangey yellow. So a 3.5 is our stereotypical traditional inpatient treatment for substance use. What we know and what this tells us, it's clinically managed high intensity. So the focus isn't medical, the focus is therapeutic clinical work with clinicians, social workers, recovery advocates to help and support move people into a recovery experience. We talked about IHOP. Oh my gosh. We talked about IOP and high op, or that old school PHP. That's in level 2 under green. So again, you'll see some options that intensive outpatient and high intensity outpatient, those are levels that we would drop down from that residential experience. Level 1 is that outpatient piece I talked about, the once or twice a week. The other piece in level 1 that you'll see is 1.0, long-term remission monitoring. So this could be a monitoring program like SoberLink, Backtrack. Karen offers My Recovery Connection, but this is some sort of monitoring to help keep track of sobriety and accountability. It could be something that engages with the family, but a lot of times it's for people who want to have another layer of accountability. The one below that is recovery residence. You'll see it doesn't have a level attached to it. So with ASAM, our 4th edition that's coming out, recovery residence is actually getting some attention. We have always worked with this in some capacity. These are our halfway houses, our sober livings, our supportive housing. Clinicians, therapies, treatment centers have recommended these to go hand in hand with IOP, with PHP in the past. But with ASAM and the 4th edition coming out, there's a lot more attention and recognition on the importance of supportive housing for people in early recovery to be able to be with other people and doing the work, building a foundation, and really engaging in early recovery rather than quickly moving home or going back to life. It's really giving attention to the needs of the patient, which as a provider is really exciting. Any questions on the levels so far? Okay. So I'm going to give you 2 slides on ASAM criteria. We talked about SUD criteria, which is the DSM piece, those 11. ASAM criteria helps us to identify the level of care. So if we have some understanding of the differences in terms of levels with residential, PHP, IOP, OP, ASAM tells us which one we have to go to. So what you'll see is there are 6 dimensions here. Going through them, dimension 1 is going to be that immediate withdrawal piece. Is our loved one intoxicated or under the influence? If they are, what's the potential for withdrawal? Or if they're not intoxicated, are they in withdrawal? And is it appropriate to discuss anti-craving medications? So if they're an alcohol user or an opiate user, do we talk about anti-craving medications that can support them through and after treatment? These are things like buprenorphine, Suboxone. They could be naltrexone, Vivitrol, but there's a whole host of MAT or medically assisted treatment medications that can help some of our loved ones. Dimension 2 is the medical section. What biomedical conditions do they have that might impact their ability to engage in treatment? Dimension 3 is the mental health section. Again, what mental health diagnoses do our loved ones have that might impact their ability to engage in treatment? Are they medication compliant or not? Are they truthful in what their trauma history and symptomology looks like? Do they have other diagnoses that might be more primary compared to substance use, or as they get sober, might become more present? Dimension 4 is readiness and motivation. We really look at this through the lens of internal, external, and mixed motivation. For the patient, for our loved ones, how motivated are they to be sober, to be abstinent? How motivated are they to be in specific levels of care? Somebody might have a lot of internal motivation to be sober and very much wants to do that work and does not want to go to residential treatment. So we're looking at that motivation as a whole. And in terms of readiness to change, it's really readiness of action. Are they willing to do the work? Is there insight or awareness to what they might need to do? Dimension 5 is relapse, continued use, or continued use problems. So this is if they were to step down to a lower level of care, residential to PHP, PHP to IOP, what's the likelihood or risk of returning to use? If they were in an outpatient level of care while having therapy and attending groups, what's the likelihood of them continuing to use in that level of care? If we put them in a higher level of care, do we then put a boundary or a barrier around their ability to use? So, really assessing, are they able or potentially able to use? And then dimension 6 is our recovery and living environment. This is what is the setup if this person were to live at home right now? Is it supportive? Are there drugs and alcohol in the home? If there are there loved ones or support systems who are able to remove those items from the home? Do they live by themselves? Is this a place where they've isolated? It's really looking at where have they come from and where could they potentially be going back. If the recovery or living environment is detrimental to sobriety efforts, then we might be looking at a higher level of care to build some foundation with that person. The ASAM criteria that you see right here is the current criteria that many clinicians and therapeutic experiences are using. I say it that way because ASAM has developed a fourth edition, which is rolling out and people are starting to use. You'll see the new 6 dimensions, there's still 6, are quite similar. Number 1 and 2 have stayed the same. Number 1, are they intoxicated or what does their withdrawal look like? How do we support with medication? Number 2 are what biomedical or health concerns does the person have? 3 continues with mental health, psychiatric and cognitive conditions. The change in 3 is we're not just looking at mental health, but cognitively, how has the person been impacted? The field is starting to see more and more people with cognitive impact because of their substance use and continued use. So we're starting to assess for that a little bit more. Number 4 is our substance use and related risk. So in the slide before, that would have been number 5. But in dimension 4, now we're looking at what is the potential of return to use and what are the high risk behaviors, what are the high risk situations associated with that return to use. Dimension 5 is the recovery environment. It used to be number 6, but we're starting to look at that a little bit earlier. And what's really neat about the new criteria is dimension 6, which is person-centered considerations. This is if we look at 1 through 5 and the ASAM recommendation should be residential, the person's not willing, maybe the family can't financially commit to that. Maybe there's not a residential location or a facility close enough to home. Person-centered considerations asks us to say if optimal recommendation is here, what is the next best thing that we can provide this person to still give them the care and the treatment that they need to move towards recovery. Clinicians, therapists, social workers, whoever's working with loved ones, we're already doing this. ASAM is just putting a spotlight in it now. So just as a reminder, if we look at those ASAM criteria, the 6 dimensions, they help the clinician or the clinical team that's working with your loved one to make recommendations for the different levels of care. So we have assessments, we get to our levels of care, and the question is, so what happens in treatment? The first thing is your loved one will probably have a couple assessments. We talk about an H&P, a PSA, and a CSSRS. We will do a lot of letters with them, but history and physical is just that. An H&P is your loved one sitting with a medical provider, going through their history and physical, talking about all those biomedical pieces that we talked about in dimension 1 and 2, and figuring out what medications they may or may not need. Do they need physical therapy? Do they need to be assessed for maybe injuries or impacts? But it's the medical piece. The PSA is a psychosocial assessment. This is talking about their substance use, their family of origin. We're going to talk about their treatment history, maybe their attempts of sobriety. Psychosocial also talks about the social and the spiritual aspects of your loved one, because treatment can't just be substance use. We're talking about the mental, emotional, physical, and spiritual well-being as well. So we assess for all of those things in a PSA. And the CSSRS is the Columbia Suicide Severity Rating Scale, or the Columbia, to be very easy. But this is a really brief and quick assessment that a lot of therapeutic environments use to assess for risk. It says suicide. We can really utilize this, though, to look for self-harm behaviors or maybe acting out behaviors. And the scale really allows just very quick insight to where a patient might be struggling, so that when we do the H&P and the PSA, we can start to tailor treatment a little bit better to them. So treatment starts with some assessments. With those assessments, we'll also look at safety. So in all 3 of those, we're going to talk to the patient, talk to their loved ones about any history of SI or SA, suicidal ideations and suicide attempts, HI and HA, homicidal ideation, homicidal attempts, and SIB, which is self-injurious behavior. We want to assess for safety and understand what behaviors have looked like under the influence and in periods of sobriety or abstinence. We want to be able to build safety plans, look at safety actions. How do we help and support your loved one while in treatment? So we'll look at all of these, but oftentimes if you're talking to a provider and we have a couple letters, these are the safety acronyms that we're going to be using. We talked a lot about substance use disorders, or SUDs, earlier, but as we talk with loved ones and you participate maybe in family programming, in family sessions with your therapist or social worker and your loved one, there can be a lot of diagnoses with a lot of letters that happen. I've listed some of the more common ones that our patients will often self-identify as having, or after a history and physical or psychological eval, they're informed of. And then we'll often go back to the family systems and say, I have PTSD or MDD, GAD, BPD. And if we don't know what any of those letters are, it just sounds like a whole lot. So I've listed some really common ones. PTSD being post-traumatic stress disorder. That is a trauma diagnosis. MDD is major depressive disorder. And again, just like everything else, there's a continuum. So major depressive disorder is one of our depressive diagnoses. Similar, GAD is one of our many anxiety diagnoses that we can have. So generalized anxiety disorder. And then BPD is borderline personality disorder. So if your loved one maybe calls you, or maybe after treatment they talk about these can be some common diagnoses with a lot of letters that we use that you might hear. If your loved one's in treatment, again, regardless of level of care, there is often this discussion of EBPs, which are evidence based practices. These are practices that have been assessed, studies have been completed on them, data has been run around best practice to support treatment modalities. So I listed 4 common ones. We talk a lot about CBT, and CBT is a really, really great intervention and is often used in a lot of treatment providers and a lot of outpatient practices. But it's cognitive behavioral therapy, really challenging the cognitions that we have and how they then direct our actions and our thoughts about ourselves. Um, DBT is dialectical behavioral therapy. So, looking at not just the black and white, but recognizing what the gray is, that middle path. MI is motivational interviewing. This is sitting with the patient, helping them to get to a place of change and their motivation for that. And then I've also listed EMDR, which is a trauma specific intervention, eye movement desensitization and reprocessing. So, this is a very specific intervention for individuals who are diagnosed with PTSD or trauma and then have been referred to that. So, a lot of times, what can happen is in an update call with a therapist, you might hear that your loved one is in the DBT tract and they're doing really well and they're completing your homework, and we're sitting there going, that sounds great. But these are some of the more common modalities and the letters that you might hear and the acronyms to give you a little insight what might be happening in treatment with those evidence-based practices. We also talk a lot about support groups. So as your loved one is engaging in some sort of therapeutic modality, their individual sessions, their group therapy experiences, we also talk about support groups. So it's not uncommon, maybe when we're talking about somebody getting ready for discharge or coming home, that we say we want them to go to AA or NA. Maybe we encourage you as the loved one to go to Al Anon or Nar-Anon. But these are going to be the support groups that we want people engaging in to build foundation, to sort of get a tribe around them, so to speak, maybe get sponsorship and guidance. So a lot of times we talk about 12-step recovery. I think AA and NA are commonly heard, but AA stands for Alcoholics Anonymous, NA is Narcotics Anonymous. Al-Anon and Nar-Anon are the support group options for you guys as family members, as siblings, as loved ones and partners. But this is the counter support group, so to speak, for us to be able to talk about how we've been impacted due to our loved ones' substance use or their journey. Smart Recovery is also another support group that a lot of people find help in. It's another way to be sober. There's no good, bad, or indifferent pieces between any of them. We encourage our loved ones in treatment, our patients, to find what fits them. So in your update calls, maybe in education, you might hear some of these as well. So traditionally, you would hear 12-step recovery. We're really taking it through the lens of support groups now. So we go through treatment. We get ready for discharge, we get ready for transfer, maybe to a different level of care. And again, this is just a reminder of what those levels of care are. So we're talking about discharge, and maybe we're leaving the residential level of care. There's more acronyms that might come along with that. So it could be maybe an ASA or an AMA discharge. Oftentimes, this happens when our loved ones do not want to be in the level of care that they are. Maybe they're struggling with that, or they just don't want to be in residential and they'd rather do an outpatient. ASA is when somebody discharges themselves against staff advice. The counterpart to that is AMA, which is against medical advice. Typically, if somebody's discharging AMA, they haven't left the detox level of care in a residential setting. Maybe they're still on a taper medication to help with withdrawal symptoms. Against staff advice is going to be more of the clinical intervention that they're not in significant risk of withdrawal, and it would be more beneficial for them to stay in that level of care. Sometimes we have to call families and inform them of an NCD discharge, which is a non-compliant discharge. This could be due to somebody acting out. Maybe they're being aggressive with a peer or a staff member. But an NCD is typically, again, another non-routine discharge, but it's going to be typically the facility moving that discharge along versus the ASA and AMA is the patient-led discharge. I talked earlier about new ASAM Dimension 3 and us assessing for cognitive impairment. So therapeutic discharge can also happen, and this might be when your treatment team calls you and we talk about needing to transfer to a more medical level of care. Maybe it is a setting where physically they have to be taken care of, or medically maybe they had to go to the hospital for something and we found a different diagnosis that's more impactful, or liver issues. But a therapeutic discharge is really when somebody needs to go to a different level of care, but they're not going because they want to end their treatment experience or the facility wants to, but we've recognized that we're not the best setting for them. So moving them along to another level of care. And there's the routine discharge, which typically means that your loved one has completed their treatment experience, whether it's the length of stay that was agreed on, or they've achieved their treatment action steps and their goals. But a routine discharge is some combination of completion of length of stay and recommendations. This is just a page, and I would encourage you to get on if you can. But on our Karen website, there's a services for family drop down, and you'll see it right at the very top of our screen. Mallory talked about this earlier, but there's a lot of resources that go along with talking about levels of care, talking about recommendations. There's a lot of resources on continued lingo, so to speak, or that language that we use. So I gave you a handful of those pieces, and there's some additional resources on that page on the Karen web page that will help to continue this conversation as well.
Thank you, Heather. That was wonderful.